Welcome back to EASD TV and to a guest that we've had before in our studio, Anette Ziegler. Annette previously talked to us about her Novo Nordisk Prize for Excellence, and she was talking about the origins of diabetes, but she's also, we like to get a lot of work out of people, she's also giving a presentation in the EASD JDRF Symposium, which is called Prevention of Type 1 Diabetes, Is It Possible? And we're making her work doubly hard on several accounts because we had been hoping that her co-speaker, Lars Steen from Norway, would be with her, but unfortunately there's a problem and he's not able to join us, so you're going to have to do double work. Annette, welcome. And you're talking about new avenues in the prevention of type 1. And I know that you've had a very extensive screening program in Bavaria, and you're based in Munich. Tell us a bit more about that and where this is going.
Yeah, thank you. So maybe I can start with saying that we have actually over the last years achieved a milestone in type 1 diabetes because there is one drug that can delay the clinical onset of type 1 diabetes, teplizumab, as a monoclonal anti-CD3 antibody, and this is a treatment that actually is only given for 14 days. And this has this delaying effect of 2 to 3 years. And this treatment was given to relatives of people with type 1 diabetes, and it took quite a while to enroll into the study. And with this achievement, I really think that we need to broaden our capability of identifying people with early stage diabetes, because we want everybody to benefit from such a treatment and not only people who are related. And this is why already some years ago we piloted a general population screening in Bavaria, and we thought that it has to be very practical, easy, feasible. So we engaged our pediatricians in the region, and I can somehow proudly say that 600 pediatricians of 900 registered are participating in this program.
That is an achievement, Annette. Respect.
And we are using capillary blood samples, so that's also relatively easy. And these samples are sent to a central laboratory for the measurement of antibodies. And the program is running, and we have over 170,000 children that participated. And we are actually offering it in the context of well-child visits. So that is very much together with a fixed program for the pediatrician, so it's easy to perform.
So what age are you? Is it newborn or is it?
No, this screening is offered at age 2 to 5 years with the possibility of rescreening a second time between 5 and 10 years. So you have the possibility to participate twice if you want. But because you said newborns, we have actually also a second large screening program, and this is in Europe, in different countries in Europe, also UK, where we screen for a genetic risk score to also in the broad population identify children at risk. And this is not for this monoclonal antibody teplizumab therapy, but for primary prevention. And where we, with therapies, try to tolerize the immune system, to reduce inflammation, and treat all these children that are at risk. And this is also running very well, and we have in Europe 350,000 plus screened.
And we were saying before we began this interview that one of the key points is that you have to have the systems in place to make sure that those results are followed up, because it's no good just finding these children. You have to make sure that something is then done for them.
Yeah, thank you for asking this. This is really very important. Monitoring and following up and taking care of these families who are either at risk from the newborns or have already an early stage disease is key and is actually more work than the screening. And we have engaged in the whole region our pediatric clinical diabetes centers so that they can take care of these families locally. The families do not have to travel to a research center. And this, I think, is very well accepted, but because that will be also, in case the child then progresses to clinical diabetes, the center of care for the future. And a similar setting we established for the newborn screening.
Now, can you speak a little bit for Lars? Because his area is more genes and environment in the development of type 1. Where are we progressing with that area?
So, of course, the genetic susceptibility is of enormous importance for this disease, and this is also why we can use this genetic risk score in the broad general population to identify children with a over 10% risk. The prevalence of diabetes in the general population is 0.4% or so, so we can enrich 25-fold just by genetics. But many data also suggest that genetics are not the only thing. It's not sufficient to start that disease. There are probably environmental factors, and there are a few factors that have consistently been shown to be associated with this disease, and one is early respiratory viral infections. And actually one study by Lars, media study, I think was the first to publish that association.
Are we talking things like respiratory syncytial virus or adenoviruses, or what particular ones are we talking about?
This is a study that Teddy has done. This was the first sequencing study. The sequencing was done not in blood but in stool samples, and from this sequencing study one found that it's actually an enterovirus B that is associated with an increased risk. And interestingly, it is actually the virus, the persistent virus that is found in several consecutive stool samples. So there may be even an incomplete immune response to the virus that is causing this long persisting shedding of the virus into the stool. So we think maybe a combination of a viral infection and a impaired immune response and the susceptibility are the fertile environment for this disease.
And what I think you're discovering is that actually there are many more undiagnosed children than perhaps we had suspected there might be.
Yeah, so what I said is that 0.4% around about have type 1 diabetes if you go until age 20 or 18 years in our population. And we were a bit surprised that we found 0.3% to have undetected, undiagnosed early stage diabetes. It's almost doubling the number of people affected.
And it'd be very interesting to follow those up, because I guess and that's always the problem with this kind of study, is that because it's such a complex interaction between genes, the environment, and viral and other infections, that actually you don't know how many of those people are going to, when you're treating them, how many of them would have gone on to actually have type 1 diabetes.
We know this already because we have already many years ago, in fact over 30 years ago, started prospective birth cohort studies where we followed people and actually have estimates how many in the natural course of the disease progress. So I think, and in all these trials when we test actually some preventive treatments, these are randomized controlled trials where we also have always a group that is not treated, a placebo group, so we can very much get an efficacy of a
so that
treatment.
You're not treating people who are not likely to go on to have the disease.
Yeah.
It's a fascinating area, Annette. It's always a joy to interview you. And if you want to see this EASD JDRF symposium, and I strongly recommend it, then of course you can find it on the EASD web service. Annette, thank you very much.
Thank you.